Good afternoon, ladies and gentlemen. My name is Marco Gourdin and I'm the Medical Director of GCRM Fertility in Glasgow. And I've been asked to talk about recurrent implantation failure and recurrent miscarriage. So what I'm going to do over the next 15 minutes or so is just explain what they are, what tests might help us to guide patients, what treatments are proven, and what the future holds. So if you remember nothing else from this talk, remember this slide. Recurrent implantation failure is not the same as recurrent miscarriage. So first of all, what do you need for implantation? You need a good quality embryo, and that means a good quality egg and a good quality sperm. And you need good quality endometrium, so that's the lining of the womb, because the embryo has to implant in the lining of the womb. And the development of the embryo has to be synchronized with the development of the endometrium. If we look first of all at recurrent implantation failure, there is in fact no universally accepted definition. But a reasonable working definition is no implantation after 3 embryo transfers of good quality embryos. But that begs the question, what constitutes good quality? And indeed, what of the patient's age? So this graph here examines the effect of age on chromosome abnormalities in embryos. So aneuploidy is a chromosomally abnormal embryo, and a blastocyst is a day 5 embryo. And an embryo has to develop to the day 5 stage before it can implant. So if an embryo stops developing before the day 5 stage, it will be universally abnormal and it won't implant. So what we see here is that as a woman gets older, the rate of chromosomally abnormal embryos rises exponentially. And the point of this is that these embryos look good, they've made it to the blastocyst stage, and yet they are still chromosomally abnormal. So by the time you get to your late 30s, early 40s, 70, 75, 80% of day 5 embryos, and the ones that make it to day 5, are chromosomally abnormal. But what this graph also shows is that even women in their early 20s still produce a substantial proportion of chromosomally abnormal embryos. So we as a species, the human species, we produce a lot of abnormal embryos. So what strategies are available for women with recurrent implantation failure? Well, the HFEA have introduced a traffic light system, whereby red means that there is no data, or there is no benefit, or indeed any treatment intervention is actually harmful. Amber means that we need more evidence from research. It may or may not be helpful, or in fact it may prove to be harmful. And then green is where it's proven to be beneficial. And they have a web link to go to the website for what they call treatment add-ons. But the red, amber, green system is a very useful way of looking at these things. And the HFEA system has been adopted by the British Fertility Society, so that's what I'm going to talk about is the red, amber, green system. So first of all, if we look at the eggs and we look at the sperm. And the first important thing to say is you can't make yourself any younger. So I've put a sad emoji and a happy emoji because I see so many patients who beat themselves up about saying, I've left it too late. Well, those are life circumstances, and we have to accept that. We just have to work with nature, so you can't beat yourself up about these things. We know that for men who have low sperm counts, antioxidant treatments like Impril do appear to help and improve the chances of pregnancy and a live birth, but they're of no obvious benefit in men with normal sperm counts. If you smoke, we know that smoking is damaging to both the eggs and the sperm, so stopping smoking is certainly beneficial. And if you're overweight, again, that's both bad for eggs or sperm, so again, losing any weight is beneficial. That's only if you're overweight. There is in fact no evidence that limiting alcohol will improve things, but essentially my motto is everything in moderation. And then thyroxine treatment, if the TSH level is greater than 4, is also beneficial, but I'll come back to that when I talk about recurrent miscarriage. And then IMSI, which is high power microscopy to choose the best sperm for injection. It was hoped that this would be beneficial, improving outcomes, but in fact there's no evidence that IMSI is beneficial at all. And then the HFEA gives pre-implantation genetic testing for aneuploidy, PGTA, previously known as PGS, gives it a red sticker because it's expensive, but in fact they also concede that the time to pregnancy and the reduction in miscarriage associated with PGTA is beneficial. So that's the other side of the coin, but I'll focus on that a bit later with recurrent miscarriage. What about the lining of the womb? Well, if you have a damaged fallopian tube, a hydrosalpinx, then clipping it or removing the tube has been shown to improve the chances of IVF by 40%, so quite a substantial increase. If you have a subserosal fibroid, so this is a fibroid that encroaches on the cavity of the womb, then removing that fibroid has also been shown to be beneficial, but it is a major operation with a long recovery time, so there are downsides to that as well. If you have a developmental abnormality of the womb, in fact there is no evidence that removing that abnormality improves things, and in fact can also be harmful. There's no evidence that using blood thinners, low molecular weight heparin injections is actually beneficial, and there's no evidence that steroids are beneficial and in fact might be harmful. There's no strong evidence that the endometrial scratch improves things, and in fact a study presented very recently at the ESHRE conference showed that in first-time IVF cycles the endometrial scratch has no benefit whatsoever. The ERA test, or endometrial receptivity array test, is quite interesting. This is looking at the synchronized development of the lining of the womb with that of an embryo. And at present there isn't sufficient data to support its use in women with recurrent implantation failure, but the data is pretty limited, and I think that does have some mileage, but not for widespread clinical use at this stage. We need more data. There's no evidence that embryo glue improves things, and in fact might be detrimental to implantation. So again, we have to be cautious about using embryo glue. And people have used Viagra in the past to thicken the endometrium, but again, there's no evidence that that is beneficial. So that's a bit about recurrent implantation failure. Let's now turn to recurrent miscarriage, also known as recurrent pregnancy loss. So first of all, what is it? Well, in fact, there is, again, no accepted definition. In the UK, we've tended to go with 3 or more consecutive pregnancy losses, but we're adopting the American and the European approach, which is 2 or more consecutive losses. These are mostly first trimester losses, so this is in the first 12 weeks of pregnancy, and thankfully second trimester losses from 12 to 24 weeks of pregnancy are thankfully very rare. And there is this concept of the endometrium being a filter. And it's this battle between the receptivity of the endometrium and the selectivity of the endometrium. So here we have highly receptive endometrium, but it's not very selective. So the endometrium will accept any abnormal embryo, the embryo will implant, but it will then go on to miscarry. At this end here, we've got endometrium that's not very receptive, but highly selective. So the embryo has to be fantastically good quality in order to implant. And what we want is something in the middle here, where you've got pretty receptive endometrium, also very selective, That's the ideal scenario. Unfortunately, we don't have a test to determine that kind of scenario. So what are the causes of first trimester miscarriages? Well, they are mostly related to the woman's age. And you've seen this graph before. As a woman gets older, the embryo is more likely to be chromosomally abnormal, so if it implants, it's more likely to miscarry. If a woman has a medical illness, such as diabetes, particularly if it's not very well controlled, then even if she gets pregnant, she's more likely to miscarry. So controlling any medical illness is a very, very good thing, because that will reduce the risk of miscarriage. I'll talk about clotting disorders in greater detail shortly, likewise thyroid disorders and the natural killer cell story. And finally, I'll give a brief overview of the progesterone deficiency story. So first of all, thrombophilias, also known as sticky blood syndrome. Well, these are uncommon, but if you have a history of recurrent miscarriage, then it's certainly worthwhile to screen for these. Unfortunately, there's limited evidence that heparin injections, so low molecular weight heparin injections, improve outcomes. But in fact, we do it anyway. We know that a low thyroid level, so hypothyroidism, is associated with an increased risk of miscarriage. And the tablet trial, which was a UK trial, and it's the largest to date, showed that even in the presence of anti-TPO antibodies, so these are thyroid peroxidase antibodies, so even if you had anti-TPO antibodies, giving thyroxine was only beneficial if the TSH level was greater than 4 milliunits per litre. What about natural killer cells? Well, the first thing to say is that the level of blood natural killer cells does not reflect the uterine, the womb natural killer cell population. They are two different species. And studies are conflicting. Some studies show that a high NK level is beneficial to implantation and pregnancy. Other studies show that it's actually detrimental. And certainly studies show that if you take a biopsy of the lining of the womb and measure the uterine natural killer cells, there is enormous cycle-to-cycle variation. So if you biopsy the womb in 3 consecutive menstrual cycles in the same woman, you'll get 3 different results. And therein lies a problem, because it's very hard then to identify which women might benefit from treatments like steroids. And at present, we have no evidence that steroids are actually beneficial. And indeed, they may be harmful, and certainly in animal studies do have potentially harmful effects on developing embryos. What about using progesterone in recurrent pregnancy loss? Well, again, we have conflicting data. The PROMISE trial, which is the largest to date, showed that additional progesterone was only beneficial if the woman had had 4 or more previous miscarriages. The PRISM trial suggested that if a woman had bleeding, giving additional progesterone was beneficial, but she had to have started bleeding first. But in fact, you needed to treat 20 women, so NNT is the number needed to treat. You needed to treat 20 women in order to prevent 1 miscarriage. And progesterone has its potential downsides. A large Israeli study showed that the incidence of autism amongst baby boys was increased by 50% in women, in the mothers who took progesterone during pregnancy. Now you do have to put that in perspective, because the background incidence of autism is about 1%, 0.9%, and this went up to 1.5%. So it's not a high increase in risk, but nevertheless it's a real increase. And certainly in animal studies, it's shown that additional progesterone does alter the biochemistry of newborn lambs if the pregnant ewes are given progesterone, and that has potential long-term implications, particularly for the blood pressure of those lambs as they turn into adults. So progesterone is not without its own risks. If we turn to pre-implantation genetic testing, so this is PGT for aneuploidy for chromosome abnormalities, previously known as PGS, pre-implantation genetic screening. And what the STAR trial showed, it was a UK trial, it showed that the time to pregnancy was quicker if you had PGTA, and if you got pregnant, miscarriage rates were lower because of course you were only transferring chromosomally normal embryos. So again, similar table, looking at management strategies for recurrent pregnancy loss. You can't make yourself any younger. You can't beat yourself up because you're 38, 39, 40 years old. That's just nature. If you smoke, in fact, once you're pregnant, there's no strong evidence that cutting smoking will reduce the risk of miscarriage, but it will reduce the risk of having a preterm birth, of having a small baby. If you're overweight, losing weight before pregnancy is a good thing. It'll improve egg quality and sperm quality, which in turn will reduce miscarriage rates. And again, once you're pregnant, cutting out alcohol, there's no evidence that will actually reduce miscarriage rates. Exercise in moderation has been shown to be beneficial, but extreme exercise is probably not a good thing. But as you're getting, as the pregnancy is developing, you're not going to be doing that anyway. As I said, in the tablet trial, there was an improvement in pregnancy rates, but only if the TSH level was greater than 4. And then PGTA does reduce the risk of miscarriage because you're only transferring chromosomally abnormal embryos. And then the jury is out on progesterone. It may be beneficial, but only if you've had 4 or more miscarriages, or if you've had some bleeding, but you need to treat an awful lot of women to prevent 1 miscarriage, and progesterone has its own potential downsides. So I'll leave you with this slide here, where it's looking at age and the number of previous miscarriages. So if a woman is 35 years old, and she's had 4 previous miscarriages, the chances of the next pregnancy being uncomplicated and carrying on to term is almost 70%. So this is really very encouraging. So having lots of miscarriages is hugely disappointing, but you have to hold on to this kind of hope. So in conclusion, there are so many things that might affect the outcome of IVF treatment, that might affect the outcome of a pregnancy. But our knowledge base is extremely limited, and the proven treatments that we can offer are again very, very limited. And there have been many, many false dawns. The sticky blood story, the natural killer cell story. And we have to be honest with patients that we are at the limit of our knowledge, and that's what research is about. You can make lifestyle changes. If you smoke, reduce smoking. If you're overweight, try and lose some weight. But what you can't do is change your age. Thank you very much for your attention. I'd be delighted to answer any questions.